COVID-19 Update, Part 2B. Let's move on to a discussion of vaccines and common concerns regarding their use for COVID. Most concerns regarding any vaccine can be categorized into three areas, which we'll discuss separately: manufacturing and production errors and contamination, lack of effectiveness, and adverse events. For the manufacturing concerns, historically it's been shown that vaccine contamination and other issues are caught early on, and it's in the best interest of the pharmaceutical companies to keep a close eye on those potential problems, in particular with sites that don't comply with processing requirements. This was illustrated early on with COVID vaccine production, where contamination led to the closing of some sites and redistribution to compliant sites. With the concern of lack of effectiveness, there are a few concerns. First, failure to reach a level of viral-specific neutralizing antibodies, and then secondly, waning levels of those neutralizing antibodies, and finally, if there's no booster, no cellular immunity. Failure to reach a level of viral-specific neutralizing antibodies is a problem with any vaccine and is both predictable and non-predictable. The unpredictable will remain so, but might have something to do with specific immune response failure that perhaps may be genetic. For the predictable, there are individuals with compromised immune systems either due to disease or medication, such as organ rejection medication, or due to age, over the age of 65, or younger individuals with comorbidities, and they're all more likely to have a depressed response to vaccines, which, in the case of the COVID vaccines, led to the recommendation that a second dose be given earlier. For those on organ rejection therapy, there were many cases of no response at all to the first shot, but a normal response to the second shot. Let's look at what is the intention of the two-shot approach and then the booster. First of all, remember the sequence of immune response to an infectious agent. Regardless of whether you've had a prior infection or have been vaccinated, COVID as a respiratory pathogen is attacked first by your innate immune system. Specifically, your nasal mucosa acts first. The status of this innate system is crucial in preventing serious disease. This is likely where normal levels of vitamin D are so important to prevent serious infection. A strong initial response with a strong interferon release correlates with those who do not have serious disease. Next, exposure to the antigens of an infectious agent like COVID results in the adaptive response that's more specific. Ultimately, it produces antibodies to fight off the initial infection, but also generates an army of memory B and T cells to fight off future infection. With the first injection of the vaccine or natural exposure, the immune response should be to reach a level of virus-specific neutralizing antibodies. A neutralizing antibody might block interactions with the host cell receptor or might bind to a viral capsid in a manner that inhibits uncoating at the genome, preventing further infection. Specifically recognizing viral antigens on virus-infected cells, which can lead to antibody-dependent cytotoxic cells or complement-mediated lysis. IgG antibodies are responsible for most antiviral activity in the bloodstream, whereas IgA is the most important antibody when viruses infect mucosal surfaces, such as COVID-19. With the second injection, the immune response should be cellular immunity, which involves the activation of phagocytes, antigen-sensitized cytotoxic T cells, and the release of cytokines and chemokines through helper T cell activation in response to the antigen. In addition, the second injection significantly boosts the virus-specific neutralizing antibody titer that has decreased over time. So without the second injection, the combination of decreasing neutralizing antibodies and no cellular immunity leaves the individual vulnerable to more serious infection, especially if immunocompromised. Related to this concept is breakthrough infection. Given COVID is a respiratory virus and not viremic, vaccines can't protect against infection. So what is the purpose of the vaccine? To fight off the infection when it occurs, like all vaccines. Patients can become mildly symptomatic because it is initially in the nasal mucosa, and it takes a day or so for the immune system to counter this infection. So the question is, should it be called breakthrough, or is this the expected result of infection after vaccination? So if measured by a PCR test, the initial load is the same regardless of your vaccination status, but T-cell activation decreases viral load within days in those that are vaccinated or in immune individuals. Remember that viral load is based on PCR, which detects viral fragments and dead viruses, not distinguishing between them. Days after, the viral load remains high in those unvaccinated, but low in those that are vaccinated or previously immune. Remember, with natural immunity, the same would occur, but in addition, there is an immune response to the viral nucleocapsid protein and other viral proteins, but with the vaccine, the immune response is only against the spike protein. Yet, what has been demonstrated recently is that vaccination induces a significant increase in a specific intermediary monocyte that significantly boosts the immune response. This does not occur with natural immunity. And for adverse events, there are a number of hypothetical issues historically based on a specific vaccine response. These include antibody-dependent enhancement and cross-reactivity, and then the identified but rare issues with the current vaccines. To be clear, there are established relationships between specific vaccines and complications. For example, smallpox can cause myocarditis, the flu vaccine can cause Guillain-Barré syndrome, a swine flu in Europe caused in rare cases narcolepsy, the rotavirus caused rare cases of intussusception, the initial whole-cell pertussis vaccine appears to have caused febrile seizures, and measles can cause thrombocytopenia. But all were detected through vaccine surveillance systems within 2 months, and several led to the development of alternate vaccines while the original vaccine was taken off the market. There are 2 types of ADE, or antibody-dependent enhancement. In either case, the immune response fails to kill the virus, allowing it to either infect macrophages or incite an immune response through binding the virus with antibodies to form immune complexes, and then this triggers a massive inflammatory reaction. An example of the failure of neutralization leading to a more severe infection occurred with the dengue vaccine. Note that these ADE events also occur with natural infection. For the ADE-related immune complex reaction, the past example was a potential vaccine for respiratory syncytial virus, which led to worsening of the disease through creation of a massive cytokine reaction to the immune complexes, again, part of the potential effect of natural infection. Bottom line, there is no evidence of ADE either through the testing of the vaccines through FDA approval, nor in the millions of individuals now vaccinated. Yet, with an actual infection, as indicated by the terms SARS, the immune complex version of antibody-dependent enhancement is likely in play, causing acute respiratory inflammation through a histamine and cytokine storm. Here's a graphical example. So now on to cross-reactivity. Several reports claim that the purported similarity between syncytin-1 and the SARS-CoV-2 spike protein may induce immune cross-reactivity, resulting in female sterility. In this particular study, they used frozen embryo transfer as a model for comparing the implantation rates between SARS-CoV-2 vaccine seropositive patients, infection seropositive, and seronegative women. No difference was found in serum HCG documented implantation rates or sustained implantation rates between the 3 groups. Reports claiming that COVID-19 vaccines or illness cause female sterility are unfounded, unquote. And in this study, their analysis demonstrated no difference in the rate of accidental pregnancies between vaccinated and unvaccinated women, and no increase in miscarriage rate. And yet, another recent study could not find evidence for an increased frequency of preterm delivery or fetal loss in women vaccinated during pregnancy, suggesting that COVID-19 vaccines do not result in pregnancy disruption. Let's move on to the individual vaccines. Their general design and the specific rare occurrences track to each. We must then always compare to the risks of natural infection for these same adverse events. For the mRNA vaccines, we have Moderna and Pfizer. These are not grown but synthesized using the code for the spike protein. They need to be modified and housed in a lipid nanoparticle for entry into the cell. The body produces the specific protein, in this case spike protein, causing an immune response specific to that protein. The mRNA exists in the cytoplasm, not in the nucleus, so there is no DNA interference. So it's important that individuals consider not only the risk of a vaccine for a particular event, but to consider it in context. People tend to judge and decide based on the vaccine without comparison to what would happen anyway or with infection. In other words, what is the risk of myocarditis on average? Then what is the risk of myocarditis if you get COVID, which then requires that you determine the risk of getting COVID. It is demonstrated that the mRNA vaccine may cause myocarditis in 1 out of 10,000 to 20,000. This is short-lived and mild in most cases. In the study in JAMA, 2.5% of athletes in the Big Ten who had COVID had myocarditis. That's 1 in 40. On to another study, myocarditis and pericarditis after vaccination for COVID-19, also published in JAMA. Looking at over 2 million vaccinated individuals, the specifics of the JAMA article were that myocarditis occurred a median of 3.5 days after vaccination. About half had Pfizer, half had Moderna. There were only 20 cases out of 2 million individuals. 75% were male with a median age of 36 years. 80% developed myocarditis after the second vaccination. Although 95% were admitted to the hospital, they were discharged within 2 days and there were no deaths. For pericarditis, 41% occurred after the first dose, 60% after the second dose. 62% were Pfizer. There were only 35 cases out of 2 million individuals. Onset was 20 days after the last immunization. 13 were admitted, but none to intensive care. A new British study was published in Nature Medicine. In this study, there are designations for the adenovirus vaccine, the Pfizer, and the Moderna vaccine in that order. So in the study, it was estimated that there were 2 cases per 1 million in the DNA vaccine, 1 in the Pfizer vaccine, and 6 in the Moderna vaccine. This was within 28 days following a first dose, and an extra 10 myocarditis events per 1 million vaccinated in the 28 days after the second dose of the Moderna vaccine. This compares with an extra 40 myocarditis events per 1 million patients in the 20 days following a positive SARS-CoV-2 test. So this indicates, on average, that myocarditis is far more common in those who get COVID than those that are vaccinated. However, that's an average, unadjusted for age. Look what happens when adjusted for age under 40. The cases per million go up to 20 with the second dose of the Moderna vaccine, which exceeds that of natural infection. Note that COVID is far riskier than the vaccines when considering pericarditis or arrhythmias. On to the DNA vaccines. These are AstraZeneca and Johnson & Johnson here in the U.S. This is a chimpanzee adenovirus carrying the vaccine. It enters the nucleus and generates the production of proteins that code for the production of mRNA for the spike protein, and then the same response as mRNA vaccines, where spike proteins exit the cell and stimulate an immune response. The main concern is vaccine-induced immune thrombotic thrombocytopenia. This is not the same as deep vein thrombosis. This clotting is unusual in that it occurs in the cavernous sinus, causing cerebral venous sinus thrombosis, and in addition may also cause intestinal thrombosis and infarct. And the thrombocytopenia associated with this condition is a condition where there is abnormally low platelet levels, which is generally unusual in someone with a major blood clot. Proposed mechanisms is binding between the adenovirus vector and platelet factor 4 occurring in the bloodstream. More often, this occurs after the first dose, within 5 to 24 days. So comparing the clotting disorder with DNA vaccines versus clotting with COVID, clotting syndrome was found in 1 out of 500,000 with the DNA COVID vaccine, but 16% of COVID patients will have clotting problems. Another concern, in particular with children, is MIS-C. This stands for multisystem inflammatory syndrome in children. This is a condition that is an acute inflammatory reaction which occurs in multiple organs, including the heart, causing myocarditis, lungs, kidneys, brain, skin, eyes, or gastrointestinal organs. So MIS-C is a condition that occurs oftentimes weeks after the infection and can hospitalize children and in some cases kill them. And finally, a publication in Morbidity and Mortality Weekly Report, COVID-19 Vaccination and Non-COVID Mortality Risk, 7 integrated healthcare organizations in the United States from December 2020 to July 2021. This was a cohort study conducted using 11 million persons enrolled in 7 vaccine safety data link sites. After adjusting for demographic characteristics and VSD site, this study found that adjusted relative risk of non-COVID-19 mortality for the Pfizer vaccine was 0.41 after dose 1 and 0.34 after dose 2. This correlates to a reduction of risk by 59% after the first dose and 66% after the second dose. The risk ratio for the non-COVID mortality for the Moderna vaccines was 0.34 after dose 1 and 0.31 after dose 2, which correlates to a 66% decrease after dose 1 and a 69% decrease after dose 2. The risk ratio after receipt of the Janssen vaccine, which is the J&J, was 0.54, which is a reduction of 46%. There was no increased risk of mortality among COVID-19 vaccine recipients. This finding reinforces the safety profile of currently approved COVID-19 vaccines in the United States. So how do we put all of this evidence into practical application? First, it's clear that with the hundreds of millions of doses, in particular the mRNA vaccines, they are incredibly safe. The rare reported events were discovered through several systems of reporting, including the Vaccine Adverse Event Reporting System, and have literally narrowed these to 2 concerns related to specific vaccine types and specific subgroups of high-risk individuals. Compared to the significantly increased risk of serious disease and death and the complications that lead to long COVID, the first recommendation is that everyone be vaccinated with a 2-dose mRNA vaccine, Moderna showing some advantage over Pfizer. And then for young men, the rare concern of myocarditis or pericarditis should be considered with the mRNA vaccines, in particular Moderna. The risk can be significantly mitigated by having only 1 dose, given most events are after the second dose. And for young women, the rare concern of thrombosis might warrant avoiding the DNA vaccines, such as AstraZeneca or J&J, and choosing one of the mRNA vaccines. For those previously infected with COVID, even a single shot of an mRNA vaccine will boost their immune response against serious disease if infected again. Next, for all immunocompromised individuals, a booster is a strong recommendation. Remember, this includes those over 65, younger individuals with significant comorbidities like diabetes and obesity, etc., and the obvious, those immunocompromised by disease or immunosuppressant medications. For all other groups, the increase in benefit from a booster compared to the 2-dose approach in preventing severe disease is not yet clear. And for those who choose not to be vaccinated, they are the group that will be at far higher risk of hospitalization and death. Eventually, like getting a cold, everyone will be exposed to COVID-19. So the question is, do you want to have an asymptomatic or mildly symptomatic response like the common cold, or do you want to run the risk of hospitalization? The good news is that it appears as of December 2021 that the Omicron variant will cause less serious disease. But as a percentage of the millions of unvaccinated individuals, this still represents a potential overwhelming burden on emergency rooms.